Hello students, welcome back. Today we begin with the second part of our topic acid-base balance. In this we are going to discuss acidosis. We will introduce ourselves with both the acidosis and alkalosis, the two major types of acid-base disorders, but alkalosis we will be taking up in next lecture, whereas in this our main focus will be acidosis. Before we begin to gather what is acidosis, let's understand a number called anion gap. In order to maintain the neutrality, it is obvious that the amount of both cations and anions is supposed to be equal. The major cations are contributed by sodium 136 milliequivalents per liter and potassium 4 milliequivalents per liter, which are frequently measured in serum. Together, these constitute 90% of serum cation. Then there are some other cations which are lower in concentration and hence constitute towards unmeasured cations. These are, for example, magnesium and calcium. Of the anions, chloride is present in largest number, 104 milliequivalents per liter, followed by bicarbonate, which is roughly about 24 milliequivalents per liter, together making up for measured anions. Rest of the anions, roughly 20%, are constituted by proteins, organic acids, phosphates, sulfates, and urate, etc., that are unmeasured anions, as these cannot be measured. We can see here that between the unmeasured cations and unmeasured anions, there is a difference in number. This difference is known as anion gap, which is about 10 to 15 milliequivalents per liter. The anion gap is thus defined as the difference between unmeasured cations and anions. Needless to mention, the concentration of measured cations and anions largely remains unchanged. Since unmeasured ions by definition cannot be measured, anion gap is calculated as the difference between measured cations and anions. We should understand here that normal anion gap is always there. It's only a matter of concern when this value varies. Either there is an increase or decrease. As we have learned in our previous lecture, body produces more acids than bases. There is always a constant effort to keep the anion gap to normal. Anion gap. It is usually due to increase in unmeasured anions and less commonly due to decrease in unmeasured cations. That is, the anions are the ones the acids are the ones which are contributing towards increased anion gap. Features of increased anion gap are a low bicarbonate and an elevated anion gap. The common causes include lactic acidosis, ketoacidosis, acute or chronic renal diseases, drug or toxin-induced increase in anion gap. Decreased anion gap. This is commonly due to an increase in unmeasured cations, mainly abnormal cations such as lithium, cationic immunoglobulins, or decreased albumin. The most common causes for decreased anion gap are lithium intoxication, plasma cell dyscrasiasis, nephritic syndrome, hyperviscosity, and severe hyperlipidemia. Let's now begin to understand the major acid-base disturbances, acidosis and alkalosis. First of all, acidosis. Acidosis is definitely the lowering in pH of the serum. The principal effect of acidosis is depression of the CNS through decrease in synaptic transmission. It causes generalized weakness, increased heart rate. Deranged CNS function becomes the greatest threat in the acidosis. Severe acidosis causes disorientation, coma, and eventually death. Whereas alkalosis is increase in pH or rise in pH of the serum. Alkalosis causes overexcitability of the central and peripheral nervous systems. It causes numbness, lightheadedness. It can also cause nervousness, muscle spasms or tetany, convulsions, loss of consciousness, and eventually death. Let's now discuss the types of acidosis and alkalosis. Broadly, acidosis and alkalosis both are of two main origins, metabolic and respiratory. The metabolic acidosis is due to decrease in bicarbonate, whereas metabolic alkalosis is due to increase in bicarbonate. The respiratory acidosis is due to increase in partial pressure of carbon dioxide or increase in concentration of carbonic acid, whereas respiratory alkalosis is due to decrease in partial pressure of carbon dioxide or carbonic acid. So one thing which is clear here and we should not confuse is that metabolic or respiratory are entirely different, and when we talk about metabolic acidosis or alkalosis, we are talking about a derangement in the concentration of bicarbonate, whereas when we're talking about respiratory acidosis or alkalosis, we are talking about derangement in the concentration of the acid, carbon dioxide or carbonic acid. Now we know metabolic acidosis is linked to bicarbonate, a drop in bicarbonate concentration. What drop in concentration of bicarbonate? The normal concentration of bicarbonate we know is around 24 milliequivalents per liter, but when the blood concentration of bicarbonate drops below 22 milliequivalents per liter, metabolic acidosis sets in. It is caused by loss in bicarbonate due to diarrhea or renal dysfunction. It is caused by accumulation of metabolic acids, fixed acids that as we discussed in previous lecture, lactic acid or ketones. How the organic acids decrease the concentration of bicarbonate? Organic acids tend to interact with the sodium bicarbonate and form sodium salts of organic acids, and CO2 is produced as a co-product. Here, the bicarbonate, the alkali reserve of the body, is being utilized to neutralize the organic acids, and hence there is a drop in bicarbonate concentration due to production of the fixed acids. Failure of kidneys to excrete endogenous fixed acids is also one of the reasons for metabolic acidosis. We already know that the acid-base disturbances are secondary to some other pre-existing clinical condition. Now, what are these conditions in case of that lead to metabolic acidosis? For example, the first one being overproduction of acids. When does overproduction of fixed acids take place? In diabetic acidosis, lactic acidosis, salicylate poisoning, methanol poisoning, ethylene poisoning, and ingestion of acid-producing substances. Another one, loss of bicarbonate. It happens in diarrhea, pancreatic fistula, ureteroenterosterostomy, renal tubular diseases. And the third one, decreased renal excretion of fixed acids, is when there is a renal failure with uremia, there is adrenocortical insufficiency, or there is carbonic anhydrase inhibitors present. Metabolic acidosis can also be characterized by high or normal anion gap conditions. I gathered these mnemonics from internet for you to understand and better remember what are the underlying conditions which are set in under high anion gap conditions or under normal anion gap conditions. So high anion gap metabolic acidosis can be learned as sad piles because it is in starvation alcoholic ketoacidosis, diabetic ketoacidosis, paracetamol parentaldehyde, increased urea, renal failure, ethanol or methanol, and salicylate. Definitely these conditions are, if you can observe properly, then these conditions are the ones which lead to rise in unmeasured anions. Now, normal anion gap metabolic acidosis, you can learn it as used car, ureterostomy, small bowel fistula, extra chlorides, diarrhea, carbonic anhydrase inhibitors, adrenal insufficiency, and renal tubular acidosis. You should understand that the normal anion gap acidosis means that all these conditions are leading to a rise in unmeasured cations and hence manifesting the metabolic acidosis. Now, how does a clinician know that it is metabolic acidosis? The patient may come with a complaint of headache, lethargy. There may be nausea, vomiting, diarrhea. Arrhythmia may be observed. Increased heart rate or increased respiratory rate, that is small breathing, may be observed. There can be a visible confusion or there can be an altogether loss of consciousness. In order to compensate for metabolic acidosis, there is an increase in ventilation by the respiratory mechanism so that excess of the carbonic acid is reduced. Renal excretion of hydrogen ions is increased manifold. Potassium ions are exchanged with excess of hydrogen ions in the ACF, which means the hydrogen ions enter the cells whereas potassium ions come out of the cells. The increased respiratory rate that we are talking about has a pattern. It is called small breathing, characterized by deep and labored ventilation. It is a correction measure for increased anion gap metabolic acidosis. Just to revisit, the causes associated with increased anion gap metabolic acidosis are ketoacidosis, diabetic ketoacidosis, uremia caused by renal failure, salicylate intoxication, starvation, methanol intoxication, alcohol ketoacidosis, unmeasured osmoles, and lactic acidosis. I'm inserting a part of this video on small breathing for the purpose of better understanding. I picked up for you guys from YouTube. You can watch the complete video from the link given below.
He's 10 years old, and you hear his breathing. This is Kuzma breathing. This is the breathing that you see with diabetic ketoacidosis. He's a little bit altered. He's a little bit slow to wake up, so he's pretty severe.
As we know that metabolic acidosis is almost always secondary to any of the multitude of underlying pre-existing clinical conditions. Thus, the first step in the treatment of metabolic acidosis is to identify the underlying cause and start a treatment for that. In addition to that, the acute cases might need clinical intervention. In that case, an intravenous solution of lactate is suggested. Although there are still more methods of treatment for metabolic acidosis, but being beyond the scope of your curriculum, those have not been included here. Hyperkalemia and metabolic acidosis are often found in association. Two separate mechanisms can be understood. Renal tubular acidosis, which is of 4 types, leads to defects in renal capacity of maintaining isohydria. Defective transporters of sodium and potassium, as shown in the picture for principal cells of collecting ducts, leads to hyperkalemia. Then in the alpha intercalated cells, the defective hydrogen ATPase transporter leads to retention of hydrogen ions in the cell, which are eventually transported to blood, leading to acidemia, as shown in the second picture. Thus, in the renal tubular acidosis, here shown type 4, hyperkalemia and acidosis are caused. In another mechanism, Acidosis causes influx of hydrogen ions inside the cell in exchange of potassium ions, which move out of the cell and lead to a rise in blood potassium ion concentration. The condition is further aggravated in diabetic ketoacidosis. As there is no insulin which helps uptake of potassium ions by cells, there still remains large amount of potassium ions outside the cells, leading to hyperkalemia. Thus, diabetic ketoacidosis may also lead to hyperkalemia in addition to renal tubular acidosis. Diabetic ketoacidosis is also linked to hypokalemia. In case of severe uncontrolled diabetes, initially there is movement of potassium ions into blood in exchange of hydrogen ions. This leads to increase in potassium concentration in blood, but it goes unnoticed as potassium ions are excreted in urine due to osmotic diuresis. But when insulin is administered, potassium ions move back inside the cells, leading to lower concentrations of potassium in blood or hypokalemia. That's why when a case of diabetic ketoacidosis is treated with insulin, potassium replacement is required with intravenous fluid and insulin as primary treatment. Hypokalemia should be taken seriously as it affects heart contractility and hence can be life-threatening. Variation of potassium concentration in relation to acidosis is frequently asked question in exams. As it is not explained as elaborately in your books, I would request you all to pay attention to it here. Let's just summarize what we have learned until now. Under the condition of isohydria, the ratio of acid to base is 1:20. When fixed acids are produced in excess, they tend to mop bicarbonate, leading to a fall in its concentration. This creates an imbalance with a fall in pH and reduced alkali reserve, shifting the ratio of acid versus alkali to 1:10. There is of course no change in the concentration of carbonic acid or carbon dioxide. In order to compensate for the fall in pH, hyperventilation or small breathing is set in to blow off the carbon dioxide. As we know, respiratory compensation is insufficient to correct the pH fall due to high amount of fixed acids. Real compensation has to set in. This ensures the excretion of large quantities of hydrogen ions while simultaneously reabsorption of bicarbonate from the renal tubular fluid, thus producing acidic urine. As the renal compensation progresses, it brings the ratio of acid versus base to 0.75:10. The therapy, if required, aims at restoring bicarbonate ion concentration. Thus, an IV solution of lactate is given, which is metabolized in liver to bicarbonate, further reinstating the carbonic acid bicarbonate ratio to 1:20. Let's get to respiratory acidosis. Respiratory acidosis is caused by a carbonic acid excess in the blood. Carbonic acid we know is measured in terms of PCO2. Normal range of PCO2 in blood is between 35 to 45 mmHg and average stands at 40 mmHg. The excess of PCO2 characterized in respiratory acidosis is above 45 mmHg. It is also known as hypercapnia. The chronic conditions which may lead to respiratory acidosis are as follows. There may be a depression in the respiratory center of brain. An overdose of narcotics might become a reason. A head injury might be there. The muscles in the chest that assist respiration might be paralyzed, or emphysema may be there. Of the acute conditions, adult respiratory distress syndrome or ARDS might be there. I hope you all must have heard a lot of this term lately. I want you all to think of it, and if you don't know yet, then search about it. Should I drop a hint? You're being forced to self-study. Well, you can tell me the answer when you return the assignments. Coming back to the acute conditions for respiratory acidosis, another reason may be pulmonary edema, pneumothorax, and mechanical As the name says, respiratory in it, there is also an excess of carbonic acid or carbon dioxide in the blood. One would easily think that compensation for respiratory acidosis should increase hyperventilation. But no, that is not the case. Remember, the respiratory acidosis is set in at the first place because of suppressed breathing due to one or the other reason. Either brain cannot send the signal or lungs cannot execute. Thus, the compensation for respiratory acidosis is set in by kidneys springing into the action. There is increased removal of hydrogen ions and simultaneous preservation of bicarbonate ions. It has been observed that in case of chronic cases, the rate of renal correction enhances and as much as 4 millimole per liter of bicarbonate ions are preserved for every 10 mmHg of the rise in pCO2. Now, how to suspect for respiratory acidosis? The patient may complain of breathlessness, restlessness, lethargy and disorientation. There may be a rapid respiratory rate, but then gradual depressed respiration. The skin may be warm and flushed due to vasodilation caused by excess of carbon dioxide, or there may be tremors, convulsions, and coma. As there is depression in respiration, in respiratory acidosis, the first step becomes to take the measures to restore ventilation. An intravenous solution of lactate should be given. As it is common with acid-base disturbances, the respiratory acidosis is also most of the times secondary to some other underlying pre-existing clinical condition. The particular clinical condition should be identified and treatment for that should be started. As in the condition of isohydria prior to onset of respiratory acidosis, the normal ratio of carbonic acid bicarbonate is 1:20. As the respiratory acidosis is set in due to suppressed breathing as a result of any of the underlying reasons previously mentioned, This retention of carbon dioxide leads to the increase in concentration of carbonic acid, shifting the ratio of carbonic acid to bicarbonate to 2:20. There is a fall in pH, increase in partial pressure of carbon dioxide, while bicarbonate concentration remains unchanged. Renal compensation sets in for correction of respiratory acidosis. More bicarbonate is reabsorbed and hydrogen ions are eliminated in the form of titratable acidity and ammonium ions, bringing the acid to base ratio to 2:30. If treatment is required, the same approach of IV lactate is followed as in case of metabolic acidosis. Listed here are the sources which I have used to prepare this lecture. With this, I thank you for being patient listeners. I hope I was able to prepare an engaging presentation. I thank you all. Until we meet for the next discussion, that will be on alkalosis.